Your patients, we are ready to start our core OB lecture now on our second day of the course. I'm Rob Pegues, one of the exam pro faculty. It's my pleasure to be with you. Thank you. We're having a little trouble with Zoom, but I think we've got it sorted out. So we will be doing from now through the end of our day today obstetrics, which is usually our first lecture in the core series. It is the most information dense and the most susceptible to new changes and updates from month to month and year to year, which I have taken care of for us. So we'll be working through this in 3 sessions. In our first session between now and about 3 p.m. Eastern, noon Pacific, we'll be doing basic obstetrics. And then in our next 2 sessions, we'll be going on to discuss high-risk obstetrics, and I have some very important updates for us at the end. Just as a reminder, and I know Dr. Foley went over this in the first lecture, we are really working on this as a focus course for you and for your case list for the examination. So again, do have your case list handy. You will want to be looking at things and making notes, particularly in this session. I will be talking repeatedly with each topic about how you would use the information we're discussing for our OB lecture update today in your examination and what to look for on your case list and what questions most likely the examiners will ask you for any given topic. And I will repeatedly say, so here's what I think an examiner would ask for this particular section if we're talking about hypertensive diseases in pregnancy. Here's how we might want to approach developing a response. And here's what's important to consider in the cases in your case list to help you to manage this. And we'll go through this topic by topic through the very end of the day and cover quite a lot of topics. There are a number of slides in here which are reference slides. They're going to be tables of things like APGARs and Bishop scores and tables of medications, things like that, which are simply for your reference. And I'll point those out so that we can move on from them. There are a number of slides that we're really going to slow down and go through in detail because they are actually very important current topics and updates. These slides were finalized in March of this year. There have been a couple of very important updates, one in April and one just this month that I do want to speak about at the end of our session today. This is particularly a new topic from June, which I believe will be very prominently featured on the exam and that we will be working on in our webinars and our mock oral sessions as we go throughout the day. And I've added into the slides here just a few sort of corrections and additional notes and references that I'll point out to you as we go along. So if everyone is ready and you have a copy of your slide manual and ready to make some notes here, we will start right in. Let me just get back to the slide we're going to start on. Good. Dr. Shamroth always insists at the very beginning that we do some brief review of statistics, and there are just a couple of important things to move through here. But in the examination, the rule, as I think we've already talked about, is that the examiner's next question comes out of the answer that I just gave to the previous question. And they sort of start very generally, and then they work their way down until they can become very sort of trivial and sort of nitpicky. But we are talking about the basics on how we identify in our patient population particular issues. We're talking about standard deviations, sensitivity, specificity, positive and negative predictive value. So just a few things to keep in mind when we're talking about standard deviations, and this comes across obstetrics, gynecology, and office practice. One standard deviation from the mean, about 2/3 out of the population, 67, 68% or so. 2 standard deviations out would be maybe the bottom 5% of the population instead of the remaining 1/3, and 3 standard deviations only down to about 0.5%, and that's an easy way to remember. Sensitivity and specificity considered more important, and sensitivity and specificity are going to refer to the patient herself. Positive and negative predictive value, as we'll see on the next slide, is going to refer to the test. And then I have an important additional slide just to go over how we get to these values. So sensitivity simply is, in obstetrics, if we're talking about screening for aneuploidy, if I'm using NIPS or cell-free fetal DNA, what is the sensitivity of our aneuploidy screening test? If the patient has a fetus with a serious aneuploidy, how likely is it that the test will pick that up? And specificity is just the other way around. And for diseases like aneuploidies, where there's a fairly low positivity in the population, the specificity is almost more important. If the patient does not have the disease, what is the likelihood that the chance will truly tell us that our NIPS or cell-free fetal DNA is negative? So the sensitivity is actually excluding false negatives, and the specificity is excluding false positives. And we'll come back to that in just a moment. Positive and negative predictive value focus not on the patient, but on the test itself. So given that I have a positive test, what are the chances that that's really true and the patient has disease? In our practice in the past 8 weeks or so, I've had a run of new OB patients who have had a positive RPR. at a low, maybe 1 to 1 or 1 to 2, and their FTA is definitely negative. So this is an issue where the test is positive, but is a false positive. The patient does not and has never actually had syphilis. So positive predictive value is, again, about ruling out the idea of false positives. We're looking at true positive versus false positives. Negative predictive value in obstetrics would likely come up in free fetal fibronectin. We're talking about preterm labor, and the examiner asked me, well, how do you evaluate a patient who comes into labor and delivery triage with potential preterm labor? And in addition to my exam, I might mention a free fetal fibronectin. The examiner's next question will be, well, tell me, what is the value of a free fetal fibronectin assay? And my answer would be, well, it's really important for its negative predictive value. If it's actually negative, how likely is it that the patient is not at risk of a preterm delivery in the next 7 to 10 days or so? So in other words, we're ruling out here false negatives with the negative predictive value. And the examiner's next question would be, well, tell me, what is the formula for determining positive or negative predictive value? So I put this slide up on the screen, which you do not have in your set. We talk about it in our live courses every year. Please take a screenshot or snap a picture of your phone with this. And these things do come up. The examiners will just keep going until we run out of things to say. And it's reasonable for them to say, well, tell me, you're looking at sensitivity. How is that defined? These formulas are actually easier than they seem. There's actually a pattern to them. So we said sensitivity and specificity focus on the patient. And sensitivity is if the patient actually has disease, how likely is it we're going to pick it up? So notice for sensitivity and specificity, the top number is true positives. And the first term on the bottom of the denominator is the same thing, true positives. And then the next term is the opposite, false negatives. Same thing for specificity. We're looking at the number of true negatives. If the patient really doesn't have the disease, how likely is the test to tell me the truth on that? On the denominator, the first term is exactly the same as the top two negatives. And the opposite, the next term is the opposite, false positives. Positive and negative predictive value are a lot easier because for PPV, everything is a positive. True positives over true positives plus the false positives, which you're trying to exclude. Negative predictive value, everything is a negative. True negatives over the true negatives plus false negatives. So that's a much easier thing to remember. But these things do sometimes come up in the exam, and we would like just to be familiar with them before we move on. Incidence and prevalence, I think we're very familiar with. In genital herpes, what if I'm working with one of my patients and she has heard concerns about genital herpes in pregnancy, she asks, what's the issue for me? And we talk about in any given year what the incidence of new cases of genital herpes is and how, if they occur during pregnancy, there's a likelihood of vertical transmission to the infant, the fetus, as opposed to peripartum or delivery transfer. The prevalence is the number of patients in the population in the United States at this time who actually have or carry genital herpes. So for the patient, that issue is relative to the entire population. What's the statistical likelihood that she may carry it without knowing it right now because she's part of the cohort of people who right now actually have the disease? Incidence is new cases, prevalence is all cases right at this point in time up to the present. We will go through when we talk about more things about high-risk obstetrics, the landmarks. These are just reference slides for you. When we're talking about epidural and spinal regional anesthesia, the landmarks is to sort of where the levels are. If we get an anesthetic level up to T4, that's kind of high at the areola. The xyphosternum still a little high. My patient may feel a little bit of shortness of breath. Umbilicus is really good for first stage of labor, and then in second stage of labor, as we'll see on the next slide, we move down to innervating the pelvic nerves, S2, 3, and 4. Dr. Shamroth, I believe it's tomorrow morning, about mid-morning, will do his lecture with you, his presentation on shoulder dystocia. And I have for about 20 years been working with him, more than 20 now. And I always make sure to attend in the live course when we can this presentation every year because it is the finest presentation on shoulder dystocia I have ever seen. And you promise you will remember this for the rest of your careers. He has videos and demonstrations, and it is excellent. And at that time, he will talk about the things like the Erb's and the Klumpke's palsies. So we're going to move on and let him do that for us tomorrow. Now, obstetrics basic principles. At this point in the live lecture, I usually ask for a show of hands from our candidates as to how many of us, if we were in our oral exam right now and the examiner would ask us, tell me, how do you perform clinical pelvimetry in your obstetrical visit? How many of us would be able to give a cogent answer comprising maybe 60 to 90 seconds or so right now? And a few people raise their hands, and often they're MFM people. This is important in the exam. All of us have inductions on our case list, and all of us have cesarean deliveries on our case list. And pretty much all of us have cesarean deliveries where there is an arrest of labor, which is a dystocia. And along in here, when the examiner is asking, tell me, how did you identify that this was the first stage arrest of labor? And you'll go through the clinical criteria, we'll talk about in a few minutes. Some of you on your case list, and this is one of the many reminders I'm going to give you throughout the session on what to watch for in your case list. Quite often we have, instead of first or second arrest, we have failure to progress or failure to descend. Some of us have CPD or cephalopelvic disproportion. That is not a term that we want to have on our case list. So we will find as we go through the season that all of us have sort of terms on our case list, which are probably not ACOG's favorite and not the best to describe. So if you have CPD on your case list, you're begging the examiner to ask you, well, tell me, what is cephalopelvic disproportion? And now you're going to be discussing pelvimetry in the exam. There are pelvic simulators in the exam these days. This is one of those things where we have to brush up a bit. So what I will do, and I think I promise you within the next 5 minutes, you will be very comfortable having about a 60-second to 75-second discussion in the exam about how to perform clinical pelvimetry, all the basics, and anything that comes up on your cases. It's usually inductions and augmentations, cesarean deliveries. You will be able to discuss this easily. So we're going to talk about the pelvic inlet, and there's only one thing to remember for the pelvic inlet. We're going to talk about the mid-pelvis, and there are only two things to remember in the mid-pelvis. And then the pelvic outlet is just the four parent pelvic types by the Caldwell-Molloy classification, and we'll walk through exactly how that works and how we sort them out and what they mean. So first, let's go to the pelvic inlet. Only a couple things for homework that I will ask you to do. If any of you have not done this already, and I hope you can see me here, as soon as you go home from this course, please, if you've not done it already, be sure to take a measuring tape and measure from the tip of your middle finger up to the crook between the index finger and the thumb, because that is what we use to identify the obstetrical conjugate. What we're looking for here is actually the diagonal conjugate. So to go back here for just a moment, what we want here for the inlet of the pelvis is the baby's head fitting between the inside of the symphysis and the sacropromontory. That's kind of the narrow isthmus there in the pelvis. We can't measure this directly because it's up inside the symphysis, so we measure it from the lower part of the symphysis back, and that is called the diagonal conjugate. And we're looking for a good 10 centimeters would be sort of a minimum nice measurement. But we do need to know this distance, tip of the middle finger up to the kind of crook between the thumb and the finger. And some of us who have smaller hands may have to kind of creep up there a little bit. But we do need to be able to tell the examiners, and you can show with your hand, that that's what we're looking for there. We're swinging from the lower part of the symphysis down to the sacropromontory right there. And we swing right down with our finger and catch that point. And then based on our knowledge, we can measure fairly accurately the number of centimeters. And that is all we need to know for the pelvic inlet. Now, what we want, of course, is the obstetrical conjugate back here. And a really good rule is if we take our diagonal conjugate, which I measured here, subtract 2 centimeters, that's a good obstetrical conjugate. So generally, obstetrical conjugate is the diagonal conjugate minus about 2 centimeters, and that will get us there. You do not need to know the linea terminalis, that's off to the side. You just need to know the symphysis pubis, sacropromontory, measure your hand, do the measurement. That's the pelvic inlet. Now, for the mid-pelvis, I'm going to have to turn this pelvis on its side and get a sagittal view in just a moment. The mid-pelvis is now measured from the inside of the symphysis right here down to the level of the deep anterior pelvic diameter. So what I'm going to do is take my finger here where I've got the sacropromontory here, and I'm just going to sweep my hand down until I come to that deepest part of the pelvis. And this is the AP diameter of the mid-pelvis. 12 centimeters is a really good measurement to stick in your head. But again, we're measuring still inside of the symphysis, but now down to the really deep hollow of the sacrum right in there. Just sweep your hand down, reach and measure. And all of us know what a 10 centimeter cervix feels like. We can add a couple centimeters to that, and we can get an idea of where we are here. 11.5, 12, I would measure 12 centimeters, and that's the important measurement. The other measurement is going to be turning on its side here. And now we're talking about the interspinous diameters. We're looking at the ischial tuberosities and the diameter between these spines. And now what I'm doing is just taking my finger and I'm just going back and forth. And again, all of us know what a 10 centimeter cervix feels like, and we're looking for a good 10 centimeters right in here. And that's the interspinous diameter of the mid-pelvis. So again, the obstetrical conjugate, just the underside of the symphysis down to the sacropromontory. The mid-pelvis AP diameter, sweep down to that deep hollow of the sacrum, and then swing your finger from side to side, and you've got the interspinous diameter. So diagonal conjugate, maybe about 12 centimeters or so, because I'd like to be 10 centimeters or more for the true obstetric. So it's about 12 centimeters for the AP diameter of the mid-pelvis, and 10 centimeters for the interspinous diameter. Now we're pretty much done. I've drawn on here, and I think you can see in your manuals that there are a couple triangles here, and they're based on the interspinous diameter of the ischial tuberosities. And the relative size and shape of these triangles inform how we get our parent pelvic types. And we very nicely have sort of an oval in here that sort of shows us the relative size of the posterior and the anterior triangles and what happens with them relative to the lateral diameter that makes them the 4 pelvic types. So this is our posterior triangle here, and this is going to go from the tip of the sacrum back here to the pubic arch up front and the interspinous diameter. So let's do these. Gynecoid pelvic type is going to be our most common. And notice it's a bit ovallate on its side. It has a fairly nice AP diameter of the pelvis, and it's got a reasonable, maybe about 11 centimeters, 12 or so, maybe for our interspinous diameter, but a little bit wider than it is high. And notice that these 2 triangles in here are roughly equal in shape. And this is the most favorable prognosis, of course, for a successful term vaginal delivery. Moving up to the anthropoid pelvis, notice that the posterior triangle is actually much smaller, because what's happened here is actually the widest diameter of the mid-pelvis is not where the tuberosities is, it's way back here in the pelvis. And that makes for a very small posterior pelvis and anterior pelvis. And note now that instead of having sort of a circle or a little bit of a horizontal oval, we now have an oval that is shaped up and down. This would be more associated with the first stage of restive labor. It could also be associated likely with an occiput posterior orientation. You can kind of see the baby's head here with the posterior here and the anterior up here. The android pelvis is simply a specialized type of the android pelvis where we have a very prominent sacrosciatic notch in here. And we've still got a pretty wide diameter here, and we've got less anterior and posterior, but we've got this little heart shape with the notch in there. So the android pelvis is actually the heart-shaped pelvis, and this is associated with a high incidence of a first stage restive labor, not being able to get to full dilation and coming down below the mid-pelvis. And finally, the platypelloid pelvis, which is really just the anthropoid pelvis turned on its side, because here we have a fairly narrow AP diameter. When I did my diagonal conjugate, it would be low, but I've got a very wide pelvis. And you can see that this would be associated with a transverse orientation of the head and perhaps a deep transverse arrest in the pelvis. So those are the 4 pelvic types, and that is all we need to know about clinical pelvic hypertrophy. Obstetrical conjugate measured by the diagonal conjugate, know your finger, from the underside of the symphysis to the sacral promontory. For the mid-pelvis, sweep down that very deep part of the pelvis down there, looking maybe for about 12 centimeters or so, as opposed to 10 for the obstetrical conjugate. Then going side to side on this interspinous diameter right here, 10 centimeters is good. And then being able to discuss, based on my measurements, how do I determine the pelvic type, sort of feeling which is the larger, the anterior, posterior, or the lateral, and where is the widest part of the pelvis? Is it at the ischial tuberosities, or is it sort of back to front? And that gives us the 4 apparent pelvic types. And that is something just to look at maybe once or twice before your examination. And just, it's very nice. Dr. Shamroth will talk about practicing in front of the mirror. Have that conversation with yourself once or twice, and I think you'll be very comfortable discussing it in the exam. And at the end of our session, I'll be very happy to go over questions as well. Very briefly, when we are doing an episiotomy, usually we'll do a medial lateral these days. What are the layers of muscles that are cut? First of all, we do the superficial transverse perineum. This is kind of out front when we're cutting like this. Right in there. Then we have the bulbocavernosus, which is one of the levators laying right in here. Bulbospongiosis is just another name for it. And the deep transverse perineal is kind of down here. It's layered underneath this. On this side, they've actually got the more superficial muscle. They've actually cut away here, and you can see the deep transverse perineal. And then we come to, of course, the external anal sphincter. So those are the layers that we should talk about anatomically, or that we may have to be shown on a point out on a slide if we're talking about episiotomy. I think we're all familiar with gravidity and parity. This is important for a couple of reasons. The first is to really, in the examination, the examiners are listening to how we speak and to the precision of the knowledge of the verbiage that we use and how we understand basic definitions and the specificities that involve in them. If you would, where I've drawn a line here across your slide, please draw a line in the slide in your book here, because up here is when I want to talk about how we determine the lie in the orientation of the pregnancy when we're assessing somebody who's coming in labor. The bottom here, attitude, synclitism, and station, and also rotation is the crucial way to get through assisted vaginal delivery, forceps and vacuum, which we're going to come to probably in about 15 minutes or so. And we have to be able to discuss this in order to persuade the examiners that we are safe in applying a vacuum or forceps to a head. We have to talk about these 3 and rotation And we're not necessarily familiar with discussing them and doing verbiage in the exam. So we'll go through that. Just like for clinical perimetry, there's a system that makes it very easy. First of all, in the examination, usually we're used to saying, well, my baby is in vertex presentation, but that's actually not true. What we have, according to Leopold's maneuvers, which is on the next slide, is a longitudinal lie. So the fetus is actually up and down as opposed to transverse or oblique. And what's occupying the lower pole is the head. It is a cephalic longitudinal lie. And then the vertex, as opposed to the brow or something else like that, is what most commonly presents. But the vertex is a couple steps in. First, we have a longitudinal lie, which can be either a cephalic lie or a breech lie. And it happens to be the cephalic lie. And then we determine the vertex or some variation thereof as the presentation. The denominator, which you'll see on your last slide, is the actual part of the presenting part that we use to determine its orientation. So occiput, anterior, posterior, transverse. For the vertex, we're looking at the very back of the head, the occiput. For the breech presentation, which would be the other type of longitudinal lie, we would use the sacrum. And this would be sacrum posterior, sacrum anterior, or sacrum transverse, just like for occiput. When we have a face presentation, it's mentum chin, and we're talking mentum anterior or mentum posterior. And of course, for the transverse lie, it is spine up or spine down. When we have an oblique lie as to how the baby is presenting, and this is less common, but we should know that for the examination, we use the acromion process of the scapular, and that is going to be anterior or posterior, depending on how the baby is rolled in the pelvis. So this is just something to come back and review in the exam. So you're talking in sort of terms that the examiners are used to hearing discussed in the examination. And Leopold's maneuvers, again, are, first of all, what occupies the lower uterine pole, which is usually the head, what occupies the upper pole, which is usually the breech, which side is the baby's spine or back on, left or right. And the fourth one is the head flexed or extended? And we don't normally do these on our exams in the office, but it's very easy, if you can see me, to demonstrate. When we have the a flexed head, and I go over the lower part of the uterus, sort of right above the symphysis pubis, it's very flat, whereas if the baby's head is extended, there will be a bump up as I come to the symphysis pubis right above it in the lower segment of the uterus, and that's how you tell that. Note that although every resident that I know these days goes through residency writing down estimate of fetal weight by Leopold's, note that the estimate of fetal weight is not part of Leopold's. Just remember that when they ask you about it in the exam. Mechanism of labor is what Dr. Shamroth is going to do in detail, and he is going to demonstrate it to you himself. It's really interesting how he does this in the examination, and you will again remember this forever. So I'm going to leave him to do that because he is excellent at it. Next, fetal heart rate tracings. In the examination, it's very important, and you may be shown fetal heart rate tracings, and usually are, to be able to discuss how we assess normal and abnormal fetal heart rate tracings. Back in the pandemic, in the 2020 examinations, when they went to Zoom exams, remote exams for the first time, there was a whole different field for the examination because it was all done online, and there was a lot of putting stuff up on the screen for us to look at, and that's where they really started doing things like that. And one of our Johns Hopkins faculty who was involved did some demonstrations with us. And I remember a really great fetal heart rate tracing that was popped up for a 34-week pregnancy. And there was some really interesting but very difficult stuff to figure out going up on the fetal heart rate tracing line that really drew our attention. And it was interesting when I presented it to candidates how they focused on that, because underneath on the TOCO line, there was contractions, like little contractions every 2 minutes or so. And it was a 34-week pregnancy. And the examiner's question is, what's your concern for this fetal heart rate tracing? And all the candidates were focusing on the stuff they couldn't understand up on the fetal heart rate tracing line, but did not notice that the patient was actually in preterm labor at 34 weeks of gestation, which was obviously the pass-fail point for that. So do remember that when we are looking at fetal heart rate monitoring, it is also the uterine activity. We're looking for the frequency of contractions. Do we have a normal pattern? Maybe an inadequate pattern by visualization, tachysystole. Then we get to the fetal heart rate tracing, baseline, variability, accelerations, and sometimes decelerations. And that's where we'll get our category 1 through 3 terminology on the next slide. Remember, we're looking for about 110 to 170 beats per minute or so as a normal fetal heart rate baseline. And we're looking for normal tachycardia or bradycardia. Variability, absent, minimal, moderate, or marked. Accelerations don't matter in category 1, 2, or 3, as we will see. It's nice to see them, but they don't define the category of tracing. And early decelerations actually don't either, but late or variable or prolonged or bradycardic contractions do, decelerations do. So I would circle those there. So in the examination, what I suggest to our candidates is really be able to describe easily a category 1 and a category 3 tracing, because they're kind of easy and specific, and everything else that you see is a category 2. So for category 1, I need to have a normal baseline. It cannot be tachycardic or bradycardic. I need to have at least moderate variability, not absent or minimal, and marked is okay. Acceleration doesn't really matter. Early decelerations are okay, but there can be a pattern or recurrent late or variable decelerations in there. And that's a reassuring tracing of normal fetal health and assay-based status. Category 3, on the other hand, which is the abnormal tracing, can have any baseline normal, tachycardic, or bradycardic, but the variability is going to be minimal or absent. And again, accelerations don't matter, but there will be a pattern or recurrence of either variable or late decelerations, and that will determine, again, where we are in the spectrum, and anything else can be category 2. So category 1 reassuring, category 3, the one that we are then going to start talking about fetal resuscitations. And I put in here, this is from last year, just as a reminder, again, our ACOG practice advisory. All of us practice in very different situations. I practice at a very large university-affiliated hospital where we do several thousand deliveries a year, and we still walk into a room and see my patients on an oxygen face mask if their tracing doesn't look quite right. Despite that, remember, as of January of last year, ACOG decided that routine use of oxygen supplementation is not useful as part of our resuscitative measures. And this comes up in the exam because your examiner will show you this fetal heart rate tracing and say, what do you think this is? And I would say, looks like it's sort of a concerning persistent category 2 tracing. And you just say, okay, how would you manage this? What he is waiting for me to say is whether I would say I would deliver the patient or not. And that determines whether it is a persistent category 2 tracing or just an initial category 2 tracing. Because if it's not obviously persistent, what he's waiting for me to say is, well, I would try some resuscitation measures first. And I would look and assess maternal fetal status in other ways. And if my resuscitation measure is not successful, it would then become a persistent fetal category 2 tracing. And that, like a category 3, is an indication for expedited delivery. And he would say, what are your resuscitation measures? And here is where, remember in the exam, it is fine to say, well, in my institution, nursing staff and staff are still actually using oxygen supplementation, but I do understand that ACOG has specifically recommended that it is not of use in fetal intrauterine resuscitation, and I should be relying on positioning, adequate hydration, and other things, but not specifically oxygen. And that's a very nice way of just saying, what you want to talk about in the exam is what we do in our practice and what's the recommended standard of care. And if anything is different, why might it be different? And I've just done that for the examiners. Well, in my hospital, people still put on oxygen face masks. ACOG says that's not really appropriate indicated anymore. It's happening, I think, just because people haven't caught up. However, ma'am or sir, if I am managing this patient, my resuscitation does not at this point include oxygen. And that's a good blueprint for getting through so many scenarios in the exam that we'll talk about as we go through the session. These are just some reminder slides. You'll be able to discuss for your biophysical profile just what you get for a score of 8 of 10 or 10 out of 10, 2 points for each one of these. Do remember and circle on the bottom here. We are always looking for a reactive NST for in 20 minutes, at least 2 accelerations. We want to go 15 beats per minute up, 15 seconds over. Remember that if we are under 32 weeks of gestation, what we're looking for is at least 10 seconds up and 10 seconds over. And in the exam, you may be shown a fetal heart rate tracing that actually is, they maybe say it's a 32-week tracing. And they would say, how do you evaluate this? And I would say, because you always want to be sure that you're thinking what your examiner is thinking. Well, ma'am or sir, you said this is 32 weeks. So below 32 weeks, I'm looking for 2 accelerations, 10 up and 10 over. And above 32 weeks, I'm looking for 15 up, 15 over. So if it's 31.5 versus 32.5, I would interpret this differently. And you've just volleyed back into the examiner's court, and the examiner knows that I understand these criteria now. He or she will either take it further or move on to something different. Management of biophysical profile, remember 8 or 10 is a normal score always. At 6, a score at full term, usually we would deliver. And if it is preterm under 37 weeks, we generally repeat in 24 hours unless there are other concerns for immediate delivery. And 4 or less is really just deliver right away. Do remember though that oligohydramnios actually in the presence of a 6 at preterm may be an indication for further evaluation. We may want to look for fetal growth restriction. There may be other indications of placental insufficiency for delivery. Most people still talk about the AFI. The sonographers would prefer deepest vertical pocket. And generally these days, a deepest vertical pocket of 5 centimeters or more would be adequate. A deepest vertical pocket of maybe 2 to 2.5 is getting down into the concern for oligohydramnios. And that's a reasonable translation. Just a couple reminders. Many of us, our nurses do the APGAR scores, and my triage practitioners, the midwives and the PAs, when the patient comes in, actually do the Bishop score before I even have a chance to get to the patient. Some of us may be out of practice with this. Do please, when you go home, this is the next bit of homework. For the next just few weeks or so, every time you deliver a baby, please do the APGARs yourself and just compare to what you get from your nurses or your neonatalists. By the time you've done this 5 times, you will be able to discuss APGARs in your sleep in the examination. It comes back very, very quickly if we're a little bit out of practice. And also for the Bishop score, they are interested when they're selecting our patients as candidates for induction as how we determine a favorable or unfavorable cervix. Why are we doing a cervical ripening rather than an immediate induction of labor? That will lead directly into your knowledge of the Bishop score. So just for your next, when you see patients in the office at full term, 38, 39 weeks, do their cervical examinations, do yourself a Bishop score. You'll probably do a dozen of them or more in a day. By the time you've done that to the end of the second day, again, you can do Bishop scores in your sleep in the examination. Just important to re-practice this because it will come up and you'll be asked to talk about it in the examination. Now, very importantly, and this comes back to our case list, so please do refer to your case list on this. What are our indications for cesarean delivery? When we talk about fetal heart rate tracings, we are talking about persistent category 2 or category 3 or something completely different. For dystocias or arrest of labors, that is where we are talking about the criteria for a failed induction of labor or for a first or second stage arrest of labor. We'll go through to the next couple of slides. And we do have to discuss for our cases that we have met the ACOG criteria. And I will come through in just a moment because most of us have on our case list cases that we have labeled failed induction or a first stage or second stage arrest of labor that actually haven't met strict ACOG criteria. And there's a very simple way of discussing that in the exam. Not just wet, but you do want to identify it rather than have your examiner pick up on it in the exam and you didn't see it coming. So failed induction, remember this does require 24 hours of without cervical change of oxytocin or of induction of labor. This is not spontaneous labor, of oxytocin, and with AROM if it is possible to do AROM. Now, in my practice, and in fact, just this past week, I did actually do a cesarean delivery on a patient about 17 hours into a term permagravid induction. I didn't meet the 24-hour criteria. I did not call it a failed induction of labor. We could have gone longer and she might have actually gone into labor, but I seriously doubt that she would have. I was able to do AROM. And what I put in my operative note was that this was a prolonged induction of labor at term with AROM, and it was induced labor, and that the cesarean was an elective cesarean upon maternal request during a prolonged induction of labor because at 17 or 18 hours, the patient was having difficulty despite a good epidural, was really having just sort of pain, pressure, discomfort. She was becoming exhausted. She was not able to proceed to 24 hours. She requested upon our discussion to move to cesarean delivery. So in the case list, that's not a failed induction of labor. That is a prolonged induction of labor with maternal request for an elective cesarean. And that's exactly what it is. An elective cesarean is what gets us out of all this stuff because in the United States, it is now a thing. So in your examination, the examiners listen very, very carefully to how you discuss this. Go through each of your cases. Be sure that you practice for yourself, that you can identify exactly, and remember how many hours if you can. If you don't have 200 cases on your case list, it's good to know details and make each of your patients an individual woman that the examiners see that you can recognize and that you work through and have provided personal care. Do be sure to discuss this as to whether it has or has not met appropriate criteria. And if it has not, it's going to be for some other reason, which again is the way of discussing. We know what the standard of care is. We know that we did something different and we know why and can tell the examiners each of those 3 things. And that is exactly what the exam is, case after case after case, all the way through, especially the OB exam. So arrest of dilation. Remember, we're now not at 4 centimeters. This has to be, in order for an arrest, it is 6 centimeters or more of dilation. Otherwise, we're talking about failed induction of labor. And there's no cervical change for 4 hours of adequate contractions. And for that, we have to have an IUPC. Or 6 hours with inadequate contractions, which can be without an IUPC. We do need to have rupture of membranes in order to identify and a first stage arrested labor. Otherwise, we're talking about failed induction, because failed induction says with or without a ROM. And I put 2 asterisks here because some of us who practice in California and on the western part of the United States, if you look at the California maternal fetal medicine criteria, I think it's a state organization that does this, it says 6 centimeters for a primigravida and 8 centimeters for a multigravida. Now, ABOG and ACOG don't say that. You don't need to mention that in the exam, but depending on where you are in the country, your case list may actually sort of be requiring that you discuss an arrest or dilation as 8 centimeters for a multigravida. Please do not worry about that in the exam. ACOG criteria are 6 centimeters. Now, second stage arrest of labor. And again, some of us are saying failure to progress or failure to descend. I think it's better in the exam to start learning how to do the terms first and second stage arrest of labor. If you stated it otherwise in your case list, that is okay. Just sort of use the terminology in the exam. For a nulliparous patient, it depends on, for an arrest, it depends on whether she does or does not have regional anesthesia. 3 hours without regional, 4 hours with regional anesthesia for pushing. For multigravida, 2 hours without regional anesthesia, 3 hours with. So just remember, for the multigravida, 2 and 3, for the nullipar, 3 and 4. Now, suppose that my patient actually has been pushing for 2.5 hours and is just exhausted and can't go further. That is not a second stage arrest of labor. That is a prolonged second stage, and without the opportunity, if they ask me to do an assisted vaginal delivery because she hasn't descended that far. And it is then, upon discussion, an elective cesarean upon maternal request during a prolonged second stage of labor. And you can tell why. You can use the term maternal exhaustion, whatever else you would like to. If it is for some other reason, like you develop a category 3 fetal heart rate tracing at 2.5 hours of second stage, then it is a category 3 fetal heart rate tracing. So first stage arrested labor, second stage arrested labor have to find those criteria. And on your case list, you may have cases that are labeled this way, but they don't quite meet the criteria. And if you're asked about it, be sure to discuss it in the way that identifies that you know the criteria. This patient was managed in a specific way that may be different. And the reason is things that happen along in labor for which often at the patient's request, if not for some other reason, we're moving to a cesarean delivery. On from that, and we'll come back to that. And that will be a great focus of our mock oral sessions, webinars as we go through the season as well. That is one of the most important parts of the examination, and it comes up very early. We talked about that in order to diagnose a first stage arrested labor, I really need an IUPC. I do have to have adequate forces. So the question from the examiners will come up is, so doctor, when would you decide to use an IUPC in your patients? The answer is not, oh, I do them in all of my inductions. That's actually not ACOG recommended, but there are specific indications. That there are 3 that we should talk about here. The first is, these days, our patients are generally of higher BMI. And it is sometimes difficult to assess uterine forces from an external monitor. And that's a perfectly appropriate indication for an IUPC. Some of us, secondly, may work in labor and delivery units where just due to nursing staffing, and especially in a smaller unit, there may not be one-to-one nursing. Our requirements in our labor and delivery is if you're being induced or augmented with oxytocin, you have to have one-to-one nursing. That is sometimes not possible. And the use of an IUPC will allow a nurse more safely to monitor more than one patient at a time for adequacy of contractions, being sure we don't get into tachysystole, keeping an eye on the fetal heart rate tracing, depending on what the contraction baseline and frequency is. That's the second reasonable one also. The third is really gets into establishing whether we have a prolonged first stage of labor or an arrest of first stage labor, and the same for a second. And that is, we are augmenting our patient and the contractions are becoming more frequent, that the patient's not making progress. Is that I just need to adjust the oxytocin and I don't yet have adequate forces, or do I have adequate forces and I'm headed maybe toward a failed induction or a first stage arrest? IUPC will answer that question. It gives us the barometric pressure in millimeters of mercury of the contractions. I calculate my Montevideo units from that. But remember, not universally for our inductions or augmentations. That's not a good answer in the exam. Now, operative vaginal delivery, and this is where we're going to come back to that syncretism, attitude, and station here. This is one of the most common, I believe, topics in the exam, and we present it as webinars every year. I will certainly be doing one in the next several weeks or so. It's important to be able to talk through when the examiner says, I see you have some vacuum, or sometimes, I hope these days, some forceps on your case list. Tell me, how do you select this patient? How do you know this patient was an appropriate candidate for a vacuum-assisted vaginal delivery? And that has to do with some very specific things like the basic criteria for when we can and cannot do a vacuum, like is the cervix fully dilated? Are the membranes ruptured? do I in fact have a cephalic vertex presentation rather than a brow or a face or a shoulder or something else like that? How is the fetal heart rate tracing, other things like that? We'll run through those in the next few slides or so. But the basic indications that I would do first is, well, I was considering it for this patient because of basically one of three things. It's in a prolonged second stage of labor and the patient is tiring. And at some point I might need to do a cesarean, but I think as I walk you through, you'll see that I felt that this was a good candidate because of the scent and the presentation of the vertex that I could do an assisted delivery and avoid a cesarean delivery. The second is we are very close to delivery and I had a fetal bradycardia or as a concerning fetal heart rate tracing, but I was fairly sure that I could deliver the patient very quickly before this got to be a problem and thereby avoid a cesarean delivery. And when we get to talk about cardiac disease in pregnancy, we'll mention that there are a few maternal indications where we do want to shorten the second stage or maybe have the patient not push very much. Most of which will deal with the first or second one of those. So the next thing, and I've highlighted this because we must say this when we're asking about how do you decide when to do a assisted vaginal delivery, is it is required that if we proceed that way, that we document first that we have a operating room available, fully staffed, anesthesia available, myself and an assistant as needed so that I can do an emergency cesarean delivery if it is not possible to do the vacuum or forceps delivery, and particularly if it's in a situation of a non-reassuring fetal heart rate tracing or some other situation of compromise. And that is pass-fail in the exam. Please circle that and asterisk it on the slide here. Remember in the exam, when you're talking about how did you assess the patient as a candidate, it's your indication. And by the way, I always make sure that I have emergency facility, cesarean facilities set up before I do this. Now, what are the contraindications? Obviously, the fetal head's not engaged or not fully dilated, the membranes are not ruptured. It's difficult to determine the orientation of the head, and that has to do with sort of capital swelling. Rarely fetal bleeding conditions, you'll be able to name one or two if they ask you about that, and that actually doesn't matter. Remember, for vacuum in particular, and usually recommended for forceps, 34 weeks and above, but not below 34 weeks for assisted vaginal delivery. Then, these are the prerequisites again. The cervix is appropriately dilated, and we go to the next slide here. Full dilation, membranes ruptured, it is vertex positioned. We appropriately positioned the patient. We've got good anesthesia. I've got facilities to do it in the labor room or in the OR. And go back to our next slide for just a moment. There we go, good. That I can describe for the examiner that I know how to appropriately place the vacuum without risk of injury to the fetus. And this is where these four things come up: synclitism, attitude, position, and station. So we'll talk about these, and in the exam, you have to describe these. And usually if I ask our candidates, and if we do this in a webinar, people are not really ready to do this. There's a very simple system for it. This has to do with figuring out where the midline sagittal suture is and how the head is oriented, so I can put the vacuum on exactly in the right place without risk of shearing the meninges and causing serious neurologic injury to the baby. So I'm going to start with synclitism. And synclitism is, if we're looking at the baby's head being up and down, like my head is right here, is the midline sagittal suture in the midline, or is it shifted off to the left and right? What we're going to talk about here is X, Y, and Z axes, and that is synclitism, attitude, and station. And the position is rotation. So synclitism is the X-axis. Is my midline sagittal suture in the midline, or is it shifted off to the left or the right, in which case it may be difficult for me to get my vacuum on and pull the head back into the midline. So that is synclitism. Attitude, the easy way to remember attitude is, I tell my residents every semester or so, is if somebody has an attitude, it's kind of like they have their nose up in the air. So attitude is the Y-axis up and down, which means when I look at my anterior and posterior fontanelles, are they appropriately placed, or am I leaning more a little bit toward a brow presentation or a deep vertex? Sort of where do I have to orient that vacuum so it goes in the appropriate position between the anterior and posterior fontanelles? So the Y-axis and the attitude is the baby's head up more like this, or the baby's head very deep down like this, or in the middle. Attitude is Y-axis. So synclitism, attitude. Station is the Z-axis, which goes from B to U. So -3, -2, -1, 0, 1, 2, 3, as I go out toward U, the descent of the head through the pelvis. And then position is just the rotation. Are we right or left occiput anterior, right or left occiput posterior? But in order to pass the examination, we have to be able to verbalize to the examiners that we understand synclitism, attitude, station, and rotation in order to persuade them that we can safely apply vacuum or forceps. If we cannot do it, the examiners cannot read between the lines and assume that we can do it. The reason people do not make it through the examination is more often than not, that they are really good doctors and they know their stuff, but that they are not able in the exam to actually talk the examiner through and tell them the specific things that are crucial safety points in delivering the baby. And this is why we're spending a few extra minutes on this. I do want to come down here. In the exam, please do not do this. It's in the practice bulletin. It says you should have an adequate pelvis. Please do not say to the examiner, and this happens all the time in our webinars, well, first, I'd be sure that we had an adequate pelvis. What's the examiner's next question? Well, tell me, ma'am or sir, doctor, how do you identify an adequate pelvis when you have a head sitting at +2 to +3 station in the pelvis? And now we feel really stupid. Because what the adequate pelvis refers to at our first obstetrical visit, we really should have done clinical pelvimetry, and it's on all our ACOG intact forms, and that's why we need to discuss clinical pelvimetry in the exam, one of many reasons. Obviously, we need to appreciate the mechanism of labor. Dr. Shamroth is going to talk about that tomorrow, and obviously we need to know how to use our forceps and our vacuum. So we talked about the basics of setting up for the delivery, and remember, circle this again, always be sure we have to tell the examiners that we are ready to go straight to the OR if there's any misadventure or lack of success in an urgent situation with our vacuum or forceps. Now, the next thing here, on the case list, for most of the case lists that we see each season, it says vacuum or forceps delivery, but it doesn't specify outlet or low, usually not mid. And that's what the examiners will want to know. And you may say, well, when the examiner is asking you, how did you determine this patient was an appropriate candidate? You say, well, I could tell that the head was at sort of +2 to +3 station. And the examiner will say, so are you talking for me here about an outlet vacuum or a low vacuum? And again, we have to know the criteria. So let's do outlet first. And forceps, you can just put /vacuum there because most of us do vacuum these days. So here are the criteria for outlet. And we have to memorize these and be able to tell the examiners this is important. We can see the fetal scalp at the introitus without separating the labia. Now that's less reliable when we've been laboring for a while because sometimes there's enough caput that if you're about a +2 station instead of +2 to +3, you may be able to see the scalp by separating labor. So that's why here, please underline this word skull. The fetal skull is at the period it's for, not the top of the head or the scalp. The bony part has to be at +2 station or it has to be below +2 station. Fetal head should be at or on the perineum. We're talking +2 to +3 station, but it is the skull. When we're talking the exam, rather than use the term head, I would really want to emphasize we use the term skull. And we do have to have OA or EP OP plus or minus 45 degrees. We can't be doing this on transverse presentations. Low forceps or low vacuum, it's +2 or a little bit higher up than for that. The skull still needs to be maybe at +2 station at least. And if it's +2 to +3, you could actually call it outlet. But the fetal head is actually not on the perineum. Remember, we're talking about the skull here, the bony part just yet. Still OA or OP plus or minus 45 degrees. A few of us do forceps with rotation for greater than 45 degrees. You're not expected to be doing that as a generalist. That's for the MFM candidates. We're always talking here about low vacuum, outlet vacuum, low forceps, outlet forceps. Mid forceps, unusual in the examination. As generalists, we generally don't want to be discussing this because we really don't have the expertise to do this safely. Then the examiners will finally come to, well, so you've told me how you can safely apply your vacuum. And by the way, they'll ask you how many pulls will you try and other things like that. And so it'll tell me what are the complications of a forceps or vacuum delivery as opposed to just doing your C-section. Maternal are very simple. Obviously, you have an obstetrical laceration, which could be a 3rd or a 4th degree, or you could have a pelvic hematoma, more likely a vulvar hematoma, sometimes a vaginal wall hematoma, and that's pretty much maternal injuries. For fetal complications, do remember that the most common one, circle this, is a retinal hemorrhage, and this is right out of the practice bulletin. Somewhere between 35 and 40% of vacuum deliveries and a fair number of forceps deliveries. And it turns out there are a number of full-term spontaneous vaginal deliveries where if you do a fundoscopic exam, you'll pick up fetal retinal hemorrhages. They resolve spontaneously in most all cases. They're not a concern, but they are, in fact, statistically the most common complication of assisted vacuum delivery, and particularly by vacuum, as it turns out. After that, what I teach the residents is just think starting sort of superficially and work our way deep through sort of the scalp and down into the skull. And the more superficial we are, the more common the complication is, but the less severe it is. And the deeper we get, the more rare it is, but the more serious it gets. So I would just start with a scalp laceration, a facial laceration for the baby. Underneath that, we just have a cephalohematoma, which is just a hematoma or a bruise in the subcutaneous tissues of the scalp. Then we get down to the subgaleal hematoma, then we go to subdural, then we go to intracranial hemorrhage as we go down, and it gets rare and rare as we go through galeal. dural, and intracranial. Most of them will be scalp lacerations or cephalhematoma. Finally, do remember in the exam, we don't do combined trial of forceps and vacuum. We try with one. If it doesn't work, we go to the OR and we expeditiously do our C-section, very high risk for the fetus. Also, in this slide, I do want to remind us also just the ANODE trial, which is now a couple years old, that it's reasonable to do a antibiotic prophylaxis in a vaginal delivery when we're doing assisted vaginal delivery or operative vaginal delivery, if we do an episiotomy or if we have a third or fourth degree laceration. At the end of our presentation in a summary slide, we'll go back through, so there's a slide on just when do we and when do we not use prophylactic antibiotics in OB01 procedures. But this is the first one. If we do an epis or a third or fourth degree laceration with any operative vaginal delivery, reasonable to give a single dose of antibiotics. Just the same as if we have any sort of complication of a third or fourth degree repair, or we're concerned, it's reasonable electively to give a single dose of antibiotics if we're doing a third or fourth degree repair by itself. As we go through this, a number of the things here we are doing in our GYN lecture, particularly things like a DVT and PE, things like blood transfusions and other things like that. We'll talk about that in postpartum hemorrhage, repair bowel or bladders, more in GYN. Shoulder dystocia, Dr. Shamroth is doing. I will do vaginal breech delivery and a couple other things, I believe, on Thursday. Here we do want to talk about emergency cesarean under local anesthesia and also about perimortem cesarean delivery, because they tend to turn up in the examination in structured cases or sometimes just off the cuff. Before we get to that, though, I do want to do macrosomia, which is actually one of our most important topics here, and I have a few notes to line in here. Again, back to our case list. Some of us actually have the term macrosomia on our case list, but we actually have to be able to describe to the examiner how we arrived at that. Because macrosomia is an absolute value. It's 4,500 grams or more. And what we want to do in the exam is always talk about suspected fetal macrosomia, because macrosomia is sort of the antepartum diagnosis when we're talking about how it influences our maternal management in labor. And in cases like this, we are only doing it really by ultrasound, and there is an inherent error in ultrasound that we'll get to in just a few minutes. Large for gestational age, or LGA, is actually a postpartum diagnosis, just like fetal growth restriction is an antepartum diagnosis and SGA is a postpartum diagnosis. So in the exam, we do want to be sure to use our terms correctly. So SGA is I deliver the baby, LGA is I deliver the baby and I weigh the baby, and the baby's weight for that weeks of gestational age is in the top 10 percentile. That's LGA. Macrosomia is something we work on. Generally, if we weigh the baby and it's over 4,500 grams, then that's a postpartum diagnosis also. But in our case list, we're talking about, if it's not a patient who's had a previous macrosomia, we're talking about a patient who actually has a suspected macrosomia. And that is the term we want to add in if it's not on our case list under the problem list. So then the examiners will ask, well, how do you determine if a baby actually has macrosomia? Well, go back here. Macrosomia itself is fairly more common than usual these days, but the real concern about macrosomia is the risk of shoulder dystocia. And then that leads directly into the question of how do we manage or counsel our patients based on risk of shoulder dystocia. So Dr. Shamroth will go over this in detail, but if we have an average full-term pregnancy without macrosomia, risk of shoulder dystocia 1 to 2%. If there actually is macrosomia, which I would only find out after delivery, because that's how we determine it, then shoulder dystocia risk goes up to about 1 chance in 6 or so. Again, most of these do not result in permanent injury, but it is a shoulder dystocia. And if you have macrosomia and diabetes, gestational or pre-gestational, generally gestational more often, then we're up to 1 chance in 4. Now, a couple things to talk about here in this slide. Fortunately, the risk of a brachial plexus injury in shoulder dystocia is very, very low. If we have a non-macrosomic injury, it may be about 1 in 1,000 or so. With macrosomia, maybe about 5%, but fortunately, most of those resolve. Here's the issue, and this is why we need to talk about suspected macrosomia always on the case list. It's very difficult to predict. When we go through this, and this is something just to write down on your slide, please. When we're doing our 38, 39-week ultrasound and finally assessing the fetal weight for a infant who is not actually macrosomic, there's about an 8% error in our measurements of full term of pregnancy. If in fact the infant is actually macrosomic, and we don't know it yet, there is a 13% error. And that is because these macrosomic babies more commonly collect their weight in the trunk rather than in the head. And the Hadlock criteria emphasize the head over the abdomen measurements, and they skew these things. So if the baby is an infant of a diabetic mother or is gaining weight more preferentially in the trunk, it is less likely that we will actually pick that up by measurements as being a larger baby. So standard error of measurement at a term pregnancy by ultrasound is about 8% for estimated fetal weight. In a baby that actually is macrosomic, or will turn out to be so, it's actually 13%, but we won't know it at that time. And that's why, please, I'm going to come to now the bottom of the slides. Please put a big box around this. These are really important. On our in our practice, I try to keep an eye on the OB problem list, and I list out specifically the independent risk factors for macrosomia, and I just chart them on the problem list. So if I have a patient, let's say, who's had some excessive weight gain in pregnancy, and she has a abnormal 1 hour GTT, but a negative 3 hour, that's 2 independent risk factors for a shoulder dystocia, and I put that on the list. Also, and this is a good time to remember, this is a pearl for the examination. When we're in the exam, the examiner will ask us, well, doctor, what would you consider to be risk factors for this condition? And it could be preeclampsia, fetal growth restriction, macrosomia, cesarean delivery, anything else like that. Quite often our minds will go blank in the exam. It just happens very often. It need not be a problem. What I always teach our candidates is, no matter what, there's a universal rule. For any condition X in this pregnancy, generally, the biggest risk factor for it is that X occurred in a previous pregnancy. So no matter what, if you can just say to the examiner, well, whatever it is we're talking about, preeclampsia, really and generally the highest risk would be if this patient had preeclampsia in the last pregnancy. And once you say that, it actually opens up your mind and you're able to talk about 4 or 5 more things. It's amazing how that works. But do remember, just if you're fishing around for something, the greatest risk factor for anything X in pregnancy is that X happened somewhere in a previous pregnancy, and you just drop that right back in. Do know these particular risk factors, because if you get 2 or 3 independent risk factors, we're now talking about a risk of macrosomia. It's sort of moving out of that, for a non-macrosomic infant, risk of shoulder dystocia moving out of maybe that 0.1 to 0.5% range. Then did want to mention a couple other things. I would jot this down because it is not in the slide. In the ACOG practice bulletin on macrosomia, which was practice bulletin 216 from back in 2020, they did mention a few things that I would just kind of write down, and I would sort of commit to the back of my mind because you might want to use them in the examination. The examiner would maybe say, well, are there anything you can do to reduce the risk of macrosomia, since you've told me that it's such a risk for shoulder dystocia? And actually there are 3 things that ACOG has put in the practice bulletin, and I would know them for the exam. The first is exercising during pregnancy. Pretty obvious. The next one is even more obvious, a low glycemic diet in a woman who is diabetic. Well, all of our diabetic patients should be on a low glycemic diet. That's part of what we do. That's really obvious. And the third one is pre-pregnancy bariatric surgery in women who have class 2 to class 3 obesity. Now, not too many people will go through that, but that's actually specifically identified by ACOG. That's something that can reduce the risk of macrosomia, which might then lead to a shoulder dystocia. So again, exercise during pregnancy, low glycemic diet in diabetic women, we all do that. And C, pre-pregnancy bariatric surgery for weight reduction prior to pregnancy in a woman who has class 2 or class 3 obesity. They may be offered that. Most of us would not come up with that as first, but those are the 3 ACOG recommendations. Now, here's the next thing. What we're dealing with here on our case list is suspected macrosomia, but that may influence our management of the patient. We're all really worried about a patient who actually has a macrosomic infant and a higher risk of shoulder dystocia. Those are awful and scary, and they can be harmful to baby and to mother. Remember, though, that ACOG does say macrosomia, suspected macrosomia is what we're going to talk about here. Suspected is not an indication for cesarean delivery or for induction of labor. Now, what that means, it's not a medically indicated induction of labor reason, but it can be an elective induction, which means at 39 to 40 weeks, you can have this on your case list. You elected to induce your patient because of suspected macrosomia. That's fine. That's not a medically indicated induction. That would be like 37 to 38 weeks. We are not doing that. It is fine if you have suspected macrosomia to electively induce your patient at 39 weeks or after. It's just you describe it to the examiner as elective induction of labor. After counseling, shared decision-making is a great term about the possibility of macrosomia and the potential risk if we went maybe 41, 42 weeks in this situation, where we really might have a much larger baby. So the cesarean delivery does go up if we do these induction for suspected macrosomia, but in an appropriate selected patient, at 39 weeks or more, and after counseling, it is appropriate. It's not clear that there's a reduction in shoulder dystocia, but that's because if you look at the last slide, the numbers are pretty low, and a non-diabetic woman is still 0.1% to 5% or so. There are, of course, indications for suspected macrosomia. If your ultrasound says you're greater than 5,000 grams in a non-diabetic woman, 4,500 diabetic, you automatically have a medical indication for inducing her, and that does reduce the risk of shoulder dystocia. We can note about that right there. We don't otherwise have interventions to reduce the likelihood of shoulder dystocia. That is true. We always talked about what's at the bottom of the slide here, but I'd like to add a couple more things that were in this practice bulletin that I would like to have you have on the slide. Also, so ACOG says there's no clear indication for medically indicated induction of labor for suspected macrosomia, definitely not for a recommendation for a cesarean, non-medically indicated cesarean for suspected macrosomia, unless you meet these weight criteria. Also, there's no contraindication to TOLAC in a patient who has suspected macrosomia, and there's no contraindication to operative vaginal delivery, forceps or vacuum in this patient, but it does say very specifically physicians should be prepared for the possibility of shoulder dystocia if you are doing an operative vaginal delivery in someone with suspected macrosomia, which is just, I think, obvious. Dr. Shamroth will mention when he does his shoulder dystocia preparation about that it actually, in order to prevent one shoulder dystocia with a actual birth injury, you'd have to do 3,700 cesarean deliveries in a non-diabetic woman, 440 cesarean deliveries in a diabetic woman. And given the baseline rate of complications of cesarean delivery, that can add up to some morbidity. So that is macrosomia. I'll be happy to go over any questions at the end of our session here. Let's move in then to emergency C-section under local anesthesia. This is something that, again, most of us have not done. In any given year, we meet a few of our candidates actually who have, but it does turn up from time to time. So this is, we have to do an emergency C-section. We don't have an anesthesiologist to help us, and the patient does not already have regional anesthesia. The most important thing is counseling and consent of the patient beforehand. The second thing is to be in an OR with complete monitoring, including your blood pressure cuff, your EKG monitoring, your oxygen saturation, and at least a nurse who can sort of stand by and monitor vital signs. The third is, what do we do for a local anesthetic? And after a lot of controversy in the past 20 years, everybody has settled on that you do 0.5% lidocaine with epinephrine, and you can use it up to a dose of 60 cc's, which is actually pretty plenty for this, but do monitor your vital signs. Along in here, they may ask you, well, you're using a lot of lidocaine. Tell me, doctor, what are the side effects of lidocaine? A favorite examiner sort of segue. This is the list here, and there's actually, I'm going to have you jot a couple of things on the slide that make this easy to remember. The first two things here are just about our mouth, and then it goes to our ears, and then it goes to our eyes, blurred vision, and then it gets into the inside of our head and the brain, and then it goes to the heart. So mouth, ears, eyes, brain, heart. That's an easy way of just sort of in your mind, if you remember that, sort of being able to discuss the one or two things that turn up as you go through increasing lidocaine toxicity from mild to really, really, really severe. On to much more basic sort of mainline stuff for the examination. How do we do an emergency C-section in the local? The key thing is minimal stimulation to the patient, being in and out quickly, minimizing dissection, minimizing manipulation of tissues for the patient comfort. So we want to stay in the midline. You want to do a vertical midline incision. We don't want to do a Fannis deal in this case. You want to just infiltrate your local in the areas where we really do have to innervate. So skin and subcutaneous tissues a little bit, but mostly skin and peritoneum. The fascia, the muscle are not innervated, and you don't need to infiltrate those really a lot. Skin, parietal, and visceral peritoneum. Visceral peritoneum is, remember, the serosa of the uterus. That actually is sensitized as well. Skin, parietal peritoneum, visceral peritoneum. Don't pack, don't manipulate the bowel, go in the midline, retractors just as you need to get the baby out. Then kind of keep your things in the midline, don't exteriorize the uterus or manipulate organs or internal tissues, and in and out quickly. Then perimortem cesarean delivery, and this came up because there was a number of years ago a really good review article in both the OB and the trauma literature on what we should think about here and what the outcomes are. The important things about neonatal survival, if we have a witnessed maternal cardiac arrest, the question was, should we deliver the baby first or should we start CPR on the mom and then work on delivering the baby at the same time? The consensus is now very firmly you deliver the baby first and then you turn your attention to the mother. And the reasons are that The placenta is a very distal end organ. It's way, way down the end. The uterine arteries are the 10th branch of the hypogastric artery, and then you've got a big placenta in there. So if you're doing CPR, you are establishing maybe about 30% of normal maternal cardiac output. And if you get down to a very distal end organ like the placenta, there is not very much perfusion. So the baby is essentially not being helped much. And the quicker we can get the baby out after arrest, the better the survival, just like if we had an umbilical cord accident. So best outcomes at 5 minutes. Within 15 minutes, you get about 2/3 survival. If we're down in getting 20, 25 minutes out, it's less than 50% survival. And that's what we would expect if we had an issue with a large abruption or an umbilical cord accident as well. The other reason is in a term gravid woman, CPR is very ineffective because of the presence of a large gravid uterus. If we can actually get the uterus out and very quickly close the incision, maternal CPR is actually much more effective if we can deliver the baby within a few minutes. And if within 5 minutes or so, or 7 minutes, you can actually get into effective CPR, that can still resuscitate the mom. So those are the important things to remember about perimortem cesarean delivery. Now we'll be up to our break and some questions in just a few minutes. TOLAC and VBAC is the last session that we're going to discuss in this part of the lecture. So do know the basic statistics these days. These are updated as of 2019. Actually, this should be 2020 or so. We're actually to about a 30%, our hospital actually runs, I think, about a 30% cesarean delivery rate. The VBAC rate is somewhere in the range of about 12 to 15%, and it seems to be very slowly coming up time after time after time. On your case list, there are a couple of things that I would like to point out. Many of us on the case list, actually under the OB problem list, actually wrote VBAC. Now, the reason we put the patients in the VBAC category is because they actually did have a successful VBAC, but their antepartum problem list for which we are doing the intervention is a TOLAC or trial of labor after cesarean delivery. So TOLAC belongs on the left-hand side of the problem list. The actual outcomes are successful VBAC, and feel free to write the word successful VBAC in when you're writing up your case list. Since we're talking about case lists that are already in, just tell the examiners it was a successful VBAC. But when we're talking about it in the exam, how do you select your patients as a candidate for not TOLAC, not VBAC, but TOLAC? You say, well, my considerations in TOLAC are, we only use the term VBAC when we're talking about the outcome of the case. Do know the basic statistics, and there are a couple things I want to mention in here about how to manage an undocumented scar. Do remember that once we get plus, it's really useful just right under twins, draw a line right across the slide here. I think we should have another line in here. Because the three above here are really pretty much baseline 1% or less risk, great candidates for TOLAC. Anything below this, generally not appropriate until we get down to about the very bottom here. So here, and here. Previous lower uterine segment rupture, previous extra segment rupture, classical uterine incision, previous myomectomy or uterine surgery that has a large and full thickness incision, not candidates for TOLACs. 1 or 2, as we'll see, low transverse cesarean deliveries. Induction of labor may increase by about 0.5% or so, but still appropriate. Contraindications really are only that there's been a previous uterine rupture. We have a non-low segment transverse or low vertical incision. A low segment transverse or a low vertical is okay, but not a classical or T. And we don't have any issue of sort of a deep uterine surgery where there's a very significant or deep incision into the uterus outside of the lower segment itself. Fine to do 1 or 2 previous low segment transverse cesarean deliveries. A low vertical really actually is okay. How do we manage the patient in the exam who has an unknown scar? And some of us may have this on our case list. This is where we go by history. So if I have a patient and wherever it was she was delivered, I can't get hold of the operative record, but she is able to tell me that she was delivered at 27 weeks of gestation under emergency circumstances, and they said they had trouble getting the baby out. I'm thinking that this is not a low segment transverse, and I think she is not a candidate for TOLAC. If, on the other hand, I can't get a hold of the record, regardless of where she was delivered, but she was delivered for a first stage arrest of labor after 18 hours of labor at full term, I think it's most likely a low segment transverse if there was not any emergent or stat indications for the delivery, and she probably would be a perfectly okay candidate. So history will give you the red flags. A twin gestation, perfectly okay in the absence of any other complications for TOLAC. Then these days in the exam, when they're talking about how do you counsel your patient about the risk of TOLAC and VBAC, we stratify it based on the indication for the previous cesarean delivery. In general, what I tell my patients is I want to know whether there was a labor dystocia involved, whether clearly a first or second stage arrest of labor, not a prolonged first or second stage, but an actual arrest. And that moves us down kind of into like the 60, 65%. And after maybe I did a calculator, they would be less likely because these have to do with maternal pelvis issues and size of baby issues, and those tend to recur in supplemental pregnancies. And with a dystocia of labor or an arrest, we have more likelihood of forces being directed up into the uterine scar and possibly a uterine scar dehiscence. If it were not for CPD, which is not for a rest of labor, we need to take that off that because we don't use the term CPD. If it were a non-reassuring fetal heart rate tracing or a breech presentation or a placental abruption and there were no other issues, we're probably talking about 80% success or so. If she's had a previous successful VBAC, even better. These days, feel free to talk about calculators if you use them. Know the calculator and know the basic criteria, but do feel free to talk about using your calculators in counseling the patient. But it comes down to the issues with the previous cesarean delivery and what things are there that might raise more of a likelihood that there would be an unsuccessful this pregnancy. Now, we are actually doing fairly well here. I'd like to get at least partway into hypertension, I think. And then we'll take a very well-deserved about 30-minute break or so. But we are a little bit ahead of schedule. Hypertension is actually the thing we'll spend the most time on as far as high risk or complicated obstetrics. And it is by far the most commonly discussed thing in the exam. In the GYN lecture, we're going to tell you that the ureter is all over the GYN exam. In the OB exam, it's hypertensive disease in pregnancy. 100% of us will be asked about hypertension in pregnancy in our case list or in a structured case or sometimes in both. So let's spend a few minutes on this and then we will actually get to some questions as we're coming toward our midday lunch break. And here I'm going to go back to how to sort of manage your exam and talk in your examination. We should be familiar with the basic classes of hypertensive disorders of pregnancy. And practice bulletin 222, which is on gestational and preeclampsia, and 203 was essential hypertension, are still really good reading for the examination. Well, on the next slide, we'll talk about how we distinguish chronic hypertension from gestational hypertension and a couple of important pearls I want you to know. And then we'll get into the preeclampsia disorders. And I do want to talk very specifically about hypertension with superimposed preeclampsia, because that is the really more dangerous animal in the hypertensive diseases. But all of us have hypertension on our case list, and most of us are expecting our examiners to ask us specifically about one thing or the another. But as we'll practice in our webinars, a very common approach is they start very superficially, and they say, oh, I see here you on your case list, you've got this woman who's 38 weeks of pregnancy and she came in labor. So suppose she's a primigravida, she came in at 38 weeks and the nurse called you from the triage area and told you that she thought she might be in labor, but that she said she was not really feeling well the past couple of days. She had a bit of a headache and she had a blood pressure of 150 over 90. How would you begin to evaluate a patient like this? And then they will just stop talking and they will just look at you. Now, there are a couple ways that you can go. You can actually jump into, well, here's how I evaluate for hypertension in pregnancy. But in terms of managing our examination, this is something I do with our candidates that actually is fairly useful, which is always to answer the question the examiner asks you and answer it the way it was defined. Because my examiner asked me, how would I start to evaluate this patient? And if we like to parse our information out and sort of volley back and forth with the examiner, I would talk about the first maybe 60 to 90 seconds of my evaluation. And I might start talking. And I would say something like this. Well, as a primigravida, she's 38 weeks, sounds like she might be in labor. She has an elevated blood pressure. I'm coming in to see her right away. And when I walk into the room, the first thing I would do, which I think all of us do, is I would look at her and I would think to myself, does she look well or does she look ill? Do I need to be immediately concerned about her and this fetus, or do I have a little time to do some checkout here? Next, my eyes are going to go to the monitor. Because remember, in obstetrics, we always have two patients. And you always want to remember when we're talking about somebody who comes in with a problem, we always are doing a basic obstetrical exam as well. I'm going to check out the monitor. So is she having contractions? How's the fetal heart rate tracing look? Do I need to be immediately concerned or are we okay? And third, I'm going to go pick up the clipboard, look at whatever the record of blood pressure says. I'd like to have more than one blood pressure in this case because there are a number of reasons why she might have one high blood pressure. And I'd like to check it out a little bit further. And then I'm going to stop talking. And I've just told the examiner that was a really good, appropriate initial evaluation of the patient. And now the examiner can say, oh, well, tell me, so what's your differential diagnosis? You said she could have hypertension for a number of reasons. What is that? And now I'm going to go into my differential diagnosis, but I've taken a couple deep breaths. Or the examiner will say, okay, tell me about varicella in pregnancy. They jump around all the time. And if they've heard me for maybe 30 seconds talk in a cogent way, they may just go on to do something else. probably they'll go on. And that's where we then want to get into the differential diagnosis, which is everything on this list, but also a lot of other things, like a woman who's in pain or is anxious going into labor. A woman who is ill for another reason may have an elevated blood pressure. A woman who is taking medication, she actually isn't feeling well because she's sick and she took a lot of Sudafed or something else. She is actually using a stimulant, an amphetamine, a drug of some kind. A number of reasons why she could have had blood pressure that are not immediate hypertensive disorders of pregnancy. And if you throw a couple of those in and you talk about chronic and gestational and preeclampsia, you got 5 or 6 things right there. Exam pro rule in the exam, again, is good differential diagnosis is 5 plus or minus 1. That's the exam pro rule. You want to be able to, for anything common, you got 4, 5, 6 things on your list, and that's a really good discussion in the exam. So briefly, gestational hypertension versus preeclampsia. The difference obviously is that gestational hypertension turns up in someone who is not previously hypertensive and resolves within about 3 months after delivery. So when we're talking about this on our case list, I do have to tell my examiner that I'm presuming, this is kind of like suspected macrosomia, I'm presuming or suspecting gestational hypertension, but I can't prove it until about 3 months postpartum. Because if her blood pressure stay up, then she actually was a latent chronic hypertensive. And if they go back down to normal, she was a gestational hypertensive. And that's the first important thing to say. Chronic hypertension would be identified as coming into pregnancy with a blood pressure that's over 140 or 90, or it happens prior to 20 weeks. The gestational hypertension is really a late second to early third trimester thing, and that will always persist. Now, on talking about hypertension in pregnancy and chronic hypertension in pregnancy, I would like you to write down something on your slide, and this has to do with our initial workup. In the past, we've always, on all of our hypertension patients, we've done a 24-hour urine, we do some lab work, we get an EKG, always get a fundoscopic exam. The 24-hour urine now, remember, has been replaced by the spot urine protein creatinine ratio. And we only do 24-hour urines in people who don't qualify based on that criteria. So the first thing we always do these days, and this should be part of everyone's new OB hypertensive workup, is we do a urine protein creatinine ratio. If it is 0.15 or less, you don't need to do a 24-hour urine. That kind of screens the patient out as being at risk of being a latent hypertensive. There are 3 reasons why we should get a 24-hour urine. The first is if your urine protein creatinine ratio is over 0.15, regardless of what else is going on. The second is if her creatinine is greater than 1.0, that suggests end organ damage related to the kidneys, which are probably an undiagnosed hypertension. And the third is if there's any other clinical evidence of end organ disease, and that could be something related to the heart. It could be on the fundoscopic examination. It could be a previous MRI or CVA history. There are a variety of different things, but the 3 things are your urine protein creatinine ratio is greater than 0.15, your creatinine is greater than 1.0, so we do need to get metabolic Pantolian disease on all these patients, or any other evidence on your exam or history of end organ disease. And those are the 3 reasons these days why we do a 24-hour urine. Preeclampsia. Gestational hypertension, usually occurring after 20 weeks, plus proteinuria. Now, I put something on the slide that's actually very important. So preeclampsia we distinguish from those other 2 things because it occurs after 20 weeks of gestation, and usually more in the 3rd trimester, with previously normal blood pressure, so not a latent hypertensive, and there is proteinuria. Now, you can use the 24-hour urine protein with the greater than 300 milligrams. What it says in the practice bulletin, I wanted to emphasize here, it says that 2+ urine dip or greater actually is our proteinuria criteria for hypertension, for preeclampsia if she has an elevated blood pressure. But it says, and this is very important, so please note it on your slide, in a patient who already has essential hypertension, who is having negative to trace proteinuria, the progression to 1+ proteinuria is actually a potential red flag that they're developing superimposed preeclampsia. So we want to be very careful about these people who are hypertensive and watch them for superimposed, because that's the dangerous one. So if you move to a 1+ proteinuria in a hypertensive who hasn't been there before, you might want to consider superimposed preeclampsia. I would mention that in the exam. And the third thing is, these days, we usually just do our protein creatinine ratio, and if it's above 0.3 at the time we're looking for preeclampsia, that's de facto evidence that the patient probably has Then preeclampsia with severe features. Now I'd like to parse the slide out a little bit. There are clinical criteria and laboratory criteria, 3 of each. So the vascular is the blood pressure 160 over 110 or greater. The second one, pull this one out and just sort of put a box around it, pulmonary edema. That's an independent pulmonary criteria, chest pain or dyspnea, evidence of pulmonary edema. The third one is cerebral, headaches and visual changes. Then there are the laboratory indices. If they have a creatinine greater than 1.1, or it's double what we may have from them before. If they have platelets, the hematologic criteria, platelets under 100,000. For hepatic, it's the elevated liver enzymes to 2 times normal, and that's where the upper quadrupane comes in. That can be a clinical criterion also. But for my basic clinical criteria, it's vascular, lung or pulmonary, and cerebral, and then there's the upper abdominal pain. And the laboratory criteria relate to the kidneys, the creatinine, the platelets, and the AST and the ALT primarily. Remember that edema is not a criterion for preeclampsia anymore. Very important. Let's see, then finally, we'll go to a break in just a minute. Essential hypertension with superimposed preeclampsia. This is the dangerous one. This is actually 3.5 times the maternal fetal risk of other disorders. So we really want to pick this one up very quickly and readily if it is there. Perinatal mortality, 3.5 times the baseline for a non-hypertensive patient, is the most dangerous both for moms and babies. So this is someone who is hypertensive who develops the new proteinuria, and again, 1+ can be the threshold. Sudden increase of blood pressures or preeclampsia symptoms, signs, or features. Now remember, for both preeclampsia in or out of hypertension, that severe range blood pressures by itself without proteinuria can actually be considered as an independent criteria for preeclampsia severe features. And finally, before I think we're going to go to our break in a moment, eclampsia. This turns up in the exam, even if we don't have it on our case list, and largely because it's important, especially in prima gravidas and people who are a little bit preterm and have atypical preeclampsia. There may be a rapid progression from preeclampsia, jumping over severe features and going straight to preeclampsia. So in all of our patients, we do want to be doing careful monitoring and observation. We want to have in the back of our minds that they actually can progress fairly quickly to eclampsia. And we'll discuss in our mock oral sessions the management of eclampsia, immediate and prolonged, and then how we decide when and how to deliver the patient. Dear circle, and just remember at the bottom of this slide here, the differential diagnosis. It would include usually a hemorrhagic stroke, which is an intracranial bleed, not a thrombotic stroke in a young person, aneurysm, seizure disorder, drug use, things like that. Finally, let's do one more thing before we go to our break here. This is actually important. Is there a way of assessing in the next pregnancy in a patient who's had preeclampsia, the risk of preeclampsia again? Yes, and it is actually by history. It is not by these commercial tests, but there is one laboratory test we should do. It's about history. Remember, the greatest risk factor for X is that X happened in the previous pregnancy. Is there a personal family history of a hypertensive disease, preeclampsia? This is just pre-gestational diabetes here, automatically high risk of preeclampsia, recurrent preeclampsia, and also multifetal gestation. The one test that we do want to do, though, in these cases is the baseline urine protein creatinine ratio. Assume that she may already be a latent hypertensive, and always check that in your hypertensive patients at the first visit and in someone with previous preeclampsia at the first visit. Urine protein creatinine ratio 0.15 or fewer. I think let's take a stop here and we'll go to some questions and then we're going to get to our exam. So I'm going to check with our course directors. I would like to stop in a minute. We have a couple of questions. Let's do those. Let's see. He said, I think you defined category 1 and 3 wrong. I understand this. Category 1 does not need accelerations. Yes, I'm sorry, that's true. I apologize, but I emphasized repeatedly, accelerations do not matter in category 1, 2, or 3. You can have them or not have them. So category 1 is normal baseline, not tachycardic or bradycardic. You have to have moderate variability or better. Accelerations do not matter. But you can have early decelerations, but you can't actually have late or variable decelerations. Thank you for bringing that one in. Let's see, and then Danny says, are we expected to calculate the estimated success rate for patients who are attempting to toe leg? No, you do not. As long as you just sort of talk about what you consider the high risk factors and those basic categorizations. The practice bulletin really just said a lot about is it a dissociative labor or non-dissociative labor? So we're talking 60 to 65%, 75 to 80% or so. And then they're based upon factors. What I was mentioning is if you use a calculator, feel free to discuss it in the exam. Please do be sure to know the calculator and sort of know the criteria that are going into your calculator. You may absolutely discuss that in the exam. You are not in any way required to do that. Absolutely not. Good. Thank you. I think that is actually our questions.